let's hear a word from this episode's advertiser. This podcast is brought to you by Sanofi Genzyme. Sanofi Genzyme has a long history of engaging and partnering with key organizations to understand what patients need and how to support them. Stay tuned to hear important recommendations from the National Comprehensive Cancer Network, or NCCN. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Zac Pitts, Certified Family Nurse Practitioner at Winship Cancer Institute of Emory University in Druid Hills, Georgia, and member of the Metro Atlanta ONS Chapter, to discuss what advanced practice providers need to know about billing for their services and updates to reimbursement through the Center for Medicare and Medicaid. Thanks for joining me today, Zac.
Oh yeah, thanks for having me.
So to start us off, CMS has a new rule that went into effect in January 2021. Can you explain what's changed and what that means for advanced practice providers for us?
Yeah, sure. Basically, it means hopefully less documentation. It no longer required as components for billing are the history and an exam. It's now based on the time you spend with the patient. That is to include time before going in to see the patient, so reviewing labs or CTs, MRIs, as well as time spent in the room with the patient.
Okay, so what are the oncology-specific considerations for billing? You know, things like survivorship visits or chemo education visits and things like that.
There's really no specifics for oncology. Those are outpatient visits. Chemo education is typically covered in a new patient visit. So that would be something that's billed under a new patient visit with regards to chemo education. A survivorship outpatient visit, again, goes back to complexity of the patient and the level of medical decision making as well as the total time that you're spending with that patient.
Okay, well, that's good to know. I think that that's definitely something over the years that has been, maybe I could say, a frustration for advanced practice providers, that, that time that they do spend with patients, especially in things like education visits, that they can now bill for that.
Yeah, as long as you're documenting specifics, it's fair game.
So what's been your experience in billing for your services under this new rule?
Again, it goes back to maybe less documentation where you don't have this long history that's essentially just been carried over from the very first time the patient was seen, with the updates added as you go along. The comprehensive physical exam is no longer required. The billing, in discussing with some of the compliance people at Emory, have indicated that a lot of providers may even be underbilling. So, more or less kind of shortchanging ourselves when it does come to the billing aspect.
I'm sure, with this change, that probably is something that as you learn how you can bill and learn this and really start taking, how else to say it, taking credit for the work that you're doing and actually being able to bill for it now, I can see where that might be the case as you are just kind of transitioning to this ability now.
Yeah, totally.
So over this past year, all the challenges that we've had, and something that has definitely evolved and kind of exploded is telehealth. So how has billing for telehealth evolved over the past year, and what challenges has that created?
So speaking on billing, it's been expanded when we first started with all of this coming up on now a year almost, there maybe wasn't as much included that providers could bill for, not just in oncology, but really any outpatient service. It was all very much limited. So it's over the last year, it's been expanded to include quite a lot of different, very specific encounters between the patient and the provider. The one stipulation with some of these telehealth visits is some allow audio and some actually require it not just to be a phone conversation, an audio conversation, but also an audio visual conversation. The CMS actually has an Excel spreadsheet that includes all those CPT codes and whether or not the audio is acceptable or whether it actually needs to be audio and visual. So it's expanded a lot.
So what are some of the challenges that this has created, though, for the providers?
I personally find a lot of the challenges to just be the technical logistics of it all. You have a patient that's scheduled for a telehealth visit, but you have to abandon the telehealth because the internet connection on one end or the other isn't the greatest. And you have really important information that you need to get across to this patient. So you more or less abandon the telehealth and you call them from the office and discuss on the phone. So that's one challenge that I've encountered. Almost every day I'm in clinic, there's a couple patients that you end up having to do that with.
I think that as we have been through this past year and experienced all of the different and the changes and with virtual everything, I feel like this has actually brought to light almost a new disparity group, maybe I could say, because we're, as you're talking about needing to do telehealth visits and things like that, I think we're realizing that there are more people that are out there that may not have access to technology or to the internet or the right type of device to be able to do these types of visits, and how we're trying to navigate that with them.
Absolutely. Unfortunately, it's a lot of our older population who isn't as savvy with the computer, and if the modem's gotten disconnected, can they get their home network back up and running for the Zoom call? It's very true.
And that education that goes with it, and wondering what kind of support they have. Do they have support of someone that does understand the technology, that can be there to help them, walk them through those and help them troubleshoot? Or like you said, maybe they're by themselves and they just aren't that tech savvy to be able to do that and understand it. So in light of that and what you talked about as the challenge, what would you say to another advanced practice provider about how to navigate these changes?
It's tough. I know Emory has gone, we're not exclusively doing telehealth visits. So there may be some cause, depending on the nature of the visit, I suppose, to actually see them in person. You try to mitigate the risk as best you can, but if it's either seeing them in a face-to-face clinic visit, or maybe not doing the visit at all because of limitations and Zoom not being able to get set up with the Zoom, you see them in person. You more or less see them however you can, even if that is a telephone call.
Right. So you talked about how you've overcome that, main issue with the Zoom, or, not having the access to an internet source, by calling them. And then, like you just said, you might have to resort to actually bringing them in and seeing them face to face, like we did a year and a half ago. So that's definitely a good way to look at what are some ways to overcome the challenges. So talking about some of the billing, can you tell us what the difference is between independent and incident to billing?
Yes. Incident to billing is for Medicare only. If the patient has a private insurance policy, incident to billing would never apply. So we'll just stick with the example of a patient who's coming in as a new patient, newly diagnosed patient, they're Medicare, and they're seen by the physician, and that, the history and physical, that initial note as a new patient is there. And this is now an established patient who 2-3 weeks later, you're now seeing, they're getting ready to start treatment. You, as the advanced practice, would be able to see this patient and bill this patient and be reimbursed 100% with incident to billing because the physician saw them first and established that diagnosis. The alternative to that is the independent billing, where you see a patient that doesn't have an established diagnosis. Let's say, for example, the same patient, the same Medicare patient comes in and they have the lung cancer diagnosis or they have a cancer diagnosis, but they're also coming in now and they're complaining of knee pain. Or if they're on a blood pressure medication and you refill the blood pressure medication, that would be reimbursed at 85% because that wasn't an established problem or diagnosis. That was something that, as the advanced practice, you diagnosed and you treat it for the first time. So it boils down to reimbursement. Billing too, as long as it's an established patient with a physician established diagnosis, it's 100%. If it's not established, then it's 85% reimbursement.
And now let's hear a word from this episode's advertiser. Tumor lysis syndrome, or TLS, is an oncologic emergency that occurs rapidly but may be preventable. Assessing your patient's risk for TLS can help guide TLS prophylaxis and treatment decision-making. The National Comprehensive Cancer Network, or NCCN, clinical practice guidelines in oncology recommend that to best manage TLS, anticipate it, and initiate treatment prior to anti-cancer therapy for patients with chronic lymphocytic leukemia, small lymphocytic lymphoma, and B-cell lymphoma. For more information, visit learnabouttLSrisk.com. So where would the education visits or something like that fall within those billing?
Just a visit that's just purely educational, chemo teaching. Again, it just goes back to how much time you're spending with the patient. If you're spending 20 minutes providing the patient with instructions on potential side effects of, a certain chemotherapy agent, that's where that code comes from. So it's all about time spent with the patient. And you, as the advanced practice, need to be as specific as possible, even including the amount of time you're spending with the patient and what you did during that time. I spent 20 minutes with so-and-so reviewing the treatment plan to include, chemo education, provided them with hard copies to take home for review. Would be, maybe some of the documentation kind of towards the end of the note that I would be sure to include.
So are those visits then, as you were talking about the independent and the incident to billing, the 85% versus 100%, are those able to be reimbursed at 100% or is that a 85%? I'm just trying to understand if it falls within one of those two or if it's a different type of reimbursement.
Well, so it provided that this is a Medicare patient, remembering that, incident 2 is only for Medicare patients. The physician that, you work with has seen this patient and established that diagnosis. Basically there's a note. The first note is from the physician saying they have, non-small cell lung cancer. And then you see them to do some education, maybe, right before they get started with treatment. That's 100%.
That's great. From going from, not being able to bill at all for those services and for those education type of visits to having them be 100%. That's amazing. What would advanced practice providers need to do to avoid errors in billing?
In talking with some of the billing and coding gurus where I'm at, it was pretty much unanimous. Be as specific as possible. Don't be vague. Include the total amount of time you spent with the patient in everything you did, both in the room with the patient, what you discussed, as well as what you did prior to even going into the room, whether it's reviewing lab work or any kind of radiology type reports. It's about being specific and including everything that you've done.
Okay, so then it's extremely important to make sure that you have complete and accurate documentation when you're seeing your patients, and then making sure you have those correct codes in for all of that billing.
Yes, and be as specific as possible with the diagnosis, not just lung cancer, but what kind of lung cancer.
So I just have a few questions for us as we finish this out. This has been, extremely helpful and explaining what these new rules are. But can you tell me what's something about reimbursement that's not often discussed, but you wish more people knew about?
I think I may have alluded to this a little earlier, and it's not the first time I've heard this, that a lot of providers may be underbilling. I think you may kind of think that it's the opposite of that. Everybody's billing for more than what they actually did. But I think a lot of times, we're possibly underbilling. We maybe could bill for that next time increment up. So that's one example of something that I think is maybe a little misunderstood.
Thanks. I think that's probably good and really good for people to hear and know, just with the changes. And since you haven't been able to do that in the past, there probably is hesitation in making sure that they are putting the time in appropriately and billing for all of the work that they're doing.
Also, it's important to remember that it's the time you spend before you even go in the room. So if you've spent a total of 20 minutes, I go back to the same examples, the labs, the vital signs. If the patient's been hospitalized since you last saw them and you're reviewing outside records, that all goes into the total time that you've spent with that patient. So if you spend 20 minutes before you even go in the room and you spend another 20 minutes in the room, it's 40 minutes.
That's really good to know. I think that that's probably an important part that folks don't necessarily think about all the time. So, what are some additional training or education that advanced practice providers need to navigate billing and coding?
Well, I would probably suggest perusing the CMS website for the updates. There's also AMA, American Medical Association, has a really useful tool. I think it's actually, with someone who is auditing a note, it's the worksheet that they would use to ensure that, everything's kosher on the documentation and the coding side of things. If you're able to look at an audit worksheet and you can check off all the boxes, then it could be a good way to, make sure you're getting everything in that you need to get in.
Well, that's great. I'm sure that would be really helpful, especially like you were saying before, making sure you have all the documentation you need, but additionally, making sure that you're actually billing for all of the work that you are doing and getting that all in there. So to finish us out, do you have any final comments for us?
It's a lot to keep up with, all the billing and coding, in addition to, just all the new treatments that are coming out, the clinical side of things, in addition to more administrative type things. It's really a lot to keep up with.
I'm sure. And I know those codes change so frequently as well. So I'm sure just, understanding and knowing what those are used for and making sure that you are getting them appropriately placed is a lot to learn, understand, and remember. Well, I thank you for joining us today. You've really given advanced practice providers some things to think about and to be able to understand what these new changes are. So thank you for taking the time and talking with me today.
Oh, of course. Of course. It was my pleasure. Thanks for having me.
Tumor lysis syndrome, or TLS, remains a life-threatening emergency that adds substantial burden in patients with hematologic malignancies. Strategies to further improve the prevention and outcomes of patients with TLS are urgently warranted. To learn more about the risk of TLS, go to learnabouttLSrisk.com. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.